Welcome to this peek at all those pills, Pharmacology 001. I'm giving you this lecture because when this program first started in 2014, at that point the college administration would not allow a psychopharmacology course as a prerequisite to getting into clinical practice. And so we've had to incorporate psychopharmacology all throughout the 3 semesters. And students gave us feedback that they really found it difficult to be thrown into the clinical practice without having any, most of them, any real good background in psychopharmacology. The other difficulty we had is that even with all the material that we had to give, we couldn't get students even to have this lecture until about topic 4, which is almost a month and a half to 2 months into the program. So we did institute psychopharmacology MSN 630 last fall, and 9 of your colleagues were able to take it. However, the rest of you in this class have not been able to take it. So I'm going to again give this lecture, which was previously topic 4 in the old versions of MSN 634. And this is absolutely just a flying glance, a peek at all those pills. I strongly recommend that you have at your side Clinical Psychopharmacology Made Ridiculously Simple by John Preston and James Johnson. This is an excellent little book, and it will give you so much help. This lecture is intended primarily just to give you an overview of all of these things before you start your first clinical day. Let's go. Hopefully by the end of this lecture, you will be able to at least be able to describe some of the major classes and subdivisions. I am going to review again the interaction of the chemical and electrical signaling that takes place in the body. We'll review the major neurotransmitters because I've been doing this stuff for going on 7 or 8 years, and it still is something that I have to go over and over. So I am going to do some repetition today in this lecture, and throughout the program we will be doing repetitions. Then we want you to be able to at least be aware of some of the major common and some of the major serious side effects associated with these medications. Also, if there's screening and monitoring that needs to be done, you'll hear about that in the full portion of the lecture, although this is just the first of 5 parts in order to get this voiceover done. And finally, hopefully it'll give you some information about basic education so that you can prepare clients for the use of your medication, their medications. Do not, I repeat, do not expect yourself to know all of this stuff immediately. This is an ongoing learning process that is maybe starting now for some of you, and definitely will be continuing throughout the rest of your professional careers for all of us. But there are some really wonderful sites that you might want to start becoming familiar with. The top one, obviously, Stahl and Neuroscience Education Institute, is from Stephen Stahl, the author of our textbooks. You can buy a membership in this, and you might want to wait a while because it is something in the neighborhood of $200 or more to become a member. And I believe you also have to renew that membership. Psychiatric Times is an online resource that you can get all the time. Then there are some psychopharmacology updates that I would recommend. The first being the Carlot Psychiatry Report, which you see there at the right in the graphic. This is a monthly report. It's usually about 8 pages. Usually each month is a particular theme. They give very unbiased information, and I love that they give a short synopsis at the end of each article with their take on whatever the issue is. It costs, I believe, about $120 a year. It used to come both as a mailed snail mail and an email format. I believe they've gone now primarily to email format. I don't remember getting a Carlot printed report for this, but Carlot report also has versions of child psychiatry, it has behavioral health, and it also has addictions, but each is a separate subscription. Then Brown University updates. This one is more useful if you want to keep up with what research is being done on the medications and what might be coming down the pipe. Then obviously Hippocrates, which is an online, you can get the app and everything else. Really good if you want it at your hand in a handheld site to give you a lot of information. Their med interaction uh, portion is good, but I think sometimes it goes way overboard with every interaction possible. And then another that is very helpful, it's all medications. You have to hone down or uh, hammer down to get to psychiatric medications, but Global Registered Pharmacist, RPH. I don't have the specific statistics at hand, but if you look at them, you will see that the use of psychopharmacology has increased tremendously in the past 10, 15 years. So much so that people think that this is now the way that mental illnesses are treated. How did it get so big so fast? Well, first of all, we've had the dominance of the medical model, where we think we can find an exact cause. We can measure X-ray, put it under a microscope, and that's what a medical illness is. And that medical model then has dominated psychiatry as well. We have a whole school of psychology called biological psychology. Then the pharmaceuticals grew so big because insurance brokers, obviously, they want the quickest and fastest solution for their buck, and so they think that medications is going to be the quick fix. Let's get we'll only pay for psych medication management. We will not pay for psychotherapy, say some insurance companies. Then the pharmaceutical companies themselves have made tremendous efforts to get their products sold. The pharmaceutical representatives that come around to offices wanting to speak with the prescribers, and you'll notice that many of them are quite young, they're quite attractive, they're well presented. It used to be also that they would bring lots of little gifts, they would sponsor wonderful dinners, and you would find that psychiatrists and prescribers then would be prescribing the newest medication that they had just received information on from the very lovely or very handsome psych rep that just came to their office. The advertising industry has played a big role in it. We are, I think, one of the only or few countries in the world that allows advertising of psychopharmacology information on television. And so you have clients coming in saying, I want this purple pill, or I want that pill that I saw that helps with sleep. I want that one with a beautiful butterfly. And then our cultural milieu. We have grown to be a society that wants a quick fix. So it has expanded enormously. And our attitude in the Alvernos program is that we do not want to rely only on pills. There has been, I think it's dying down, but there was for a long time a big debate about which is better. Is it psychopharmacology or is it psychotherapy? Back and forth and back and forth. To me, it is not an either or approach. It's definitely a both and. In many cases, medications do make a big difference. However, in most cases, it shouldn't be a fact of meds only. When trying to organize in my mind the vast amounts of information around psychotropics, I find it helpful to think in terms of clans and families. So we have 7 major clans, so to speak, of psychotropics, and they are listed here. I've put them in the order that you'll find them in your Preston and Johnson book. The antidepressants, mood stabilizers, which are for bipolar illness, the anxiolytics for anxiety disorders, obviously the antipsychotics for schizophrenia, psychotic spectrum. Then chapter 6 of Preston is miscellaneous disorders. That's stimulants, which are for attention deficit, and cognitive enhancers, which are for the dementias. And then finally, I consider sleep inducers almost a separate category because sleep is such a major issue in our work. I don't belong to the school of psych mental health that believes that medications are the primary way that we treat people. I belong to the school that believes that we need a holistic picture. We need to do a full biological, social interventions as much as possible. And my master's degree is both in nursing, but I also have my master's degree in community counseling, and I worked for over 8 years as a licensed professional counselor. Then I went back and got my training as a psych mental health nurse prescriber. Throughout that entire period, I was working at the 16th Street Community Health Centers, where I have returned to work in the past couple of months. And I remember very clearly when I made the switch from an LPC role into the APNP psych mental health role, one of my colleagues came up to me one day and said, "Ricardo, don't you miss doing therapy?" And I looked back at her, raised my eyebrows, and said, "And what makes you think I have stopped doing therapy?" So in my office there years ago at the 16th Street Clinic, when I made that switch from licensed professional counselor to psychiatric mental health nurse practitioner, I literally went and found these two images that are on this slide, and I put them in a frame and had them behind me on the wall, whereas clients were looking at me, they would see these pictures, and I use this very often in order to teach clients about medications. They are training wheels for balance. They are not motors for mountains. You have to ride the bike of your life. And so these medications may give you some balance and stability as you're going through rough periods or as you're learning new skills, but they are not motors to get you up mountains or around or over mountains of problems. And so when clients would come in and they'd look at me and say, "These medications aren't working," I would counter with, "Well, let's look at it. Is it the medication or is it the mountain?" I'm going to fly through the next few slides because we just covered this in the lecture on neurobiology. But remember, what do you know already? You know that there is one brain. It has two hemispheres, left and right, and they really do have separate lives. They have separate functions that overlap, and they communicate with each other primarily through an area of the brain called the corpus callosum. If you want a fabulous and fascinating insight into how the different hemispheres of the brain work, you might want to Google In Stroke of Genius by Jill Bolte, B-O-L-T-E, Jill Bolte, A Stroke of, not Genius, Insight. Then we have three levels to the brain: the cerebellum, the limbic, and the cerebral cortex. And the limbic and the cerebral cortex are the areas that are going to figure so largely in all of our work and all of your professional career. And then we have the four lobes: the frontal, temporal, parietal, and occipital. And as you by now are aware, the frontal, prefrontal area, especially the dorsolateral and the ventral medial prefrontal cortexes, are the ones that figure so largely in our work, along with the temporal lobe, because it is there that if you fold your fingers over your thumb, you are enclosing the limbic system that is on the thumb, and that is connected to the underneath the ventral medial and also the full cortex. So keep this all in mind, please. By now, these areas are becoming quite familiar to you, and I can assure you that as you progress through our program, you'll be able to say these things in your sleep. But the prefrontal cortex with the prefrontal orbital cortex is that which is involved in our attraction and impulses. The dorsolateral prefrontal cortexes are for our executive functions and decision making, and this is the area of the brain that's implicated in depression, anxiety, attention deficit, impulse control, and in schizophrenia. Now, depending upon which resource you read, there are different names for different regions, and I find this can be rather confusing. But there is the insula with the anterior cingular cortex, and again, if you had folded your hand over your thumb, your fingers over your thumb, that area on the inside of your hand that's folding over, there again around the base of your fingers, some of that area is the insula, and it is there that a very important region, the anterior cingular cortex, the ACC, is located, which is very involved in our focus and our attention, and it's implicated in obsessive compulsive, attention deficit, and in substance abuse disorders, because it's also in that insula that we find the nucleus accumbens. Then, by now, the limbic system, very familiar to you, all along the thumb, the three regions, the amygdala, which is the fear center and warning, the hippocampus, which is the memory center, and the hypothalamus, which is the kind of a relay center. These are implicated in depression, anxiety, PTSD, schizophrenia. And again, remember, if you fold your hand, I love this expression, you know how we say we flip our lid? Well, take your fingers after they've folded over your thumb and now bring them up, and you will notice that all the higher functions of the cortex have now disconnected from the amygdala and the amygdala and the limbic region, and it's the amygdala and the limbic region that is the elephant that drives our lives. And once we have disconnected the rider, which is the upper cortex, the executive function and thinking powers. Once we've disconnected that, boom, flipped our lid, we are roaring, raging elephants on a rampage down the road. Just want to remind you real quickly that our brain is also an electrical system, the nervous system, and it's a mystifying blend of both chemical and electrical activity with over 100 billion neurons in our brain, each with a potential of over 10,000 connections. And the neuron is formed with the soma, or the body, that receives messages coming in through the dendrites. It encodes these messages and makes decisions about what to do, and then sends those mandates down the axon into the axon terminals, where there are these vesicle sacs that are going to release some chemicals into the synapse, which is that tiny space or cleft between the axon, the dendrite, and the axons. This slide was in our previous lecture on overview of neurobiology, but I put it here again just to keep refreshing your memory that neurotransmitters are formed from precursor elements within the axon terminal in different regions of the brain. The Raphe nucleus for serotonin, the locus coeruleus for norepinephrine, and the substantia nigra in the ventral tegmentum area. In these areas, there are enzymes that work to take those precursor elements and form them into the major transmitters, neurotransmitters, that are then stored in vesicle sacs. Those vesicle sacs then are activated by an electrical impulse that causes a process called exocytosis coming out of the little cell area. Then the neurotransmitter, or in this graphic, the blue dot, is released into the synaptic cleft, and it can either bind to receptors on the postsynaptic membrane, or it can bind to receptors on the presynaptic membrane. The presynaptic membrane receptors are by and large, but not always, autoreceptors which regulate the flow of the neurotransmitter into the synapse. They either can slow down, stop the flow, or they enhance the flow. From your general advanced pharmacology course and from your experience in nursing already, you know that medications are classified also whether they are antagonists at the receptor site, whether they're agonists at the receptor site, and they can be full and they can be partial agonists, full and partial antagonists, and it can get very, very confusing. We say a partial agonist, listen closely, a partial agonist has a net effect of increasing the neurotransmitter when there is a deficit of the neurotransmitter, but has a net effect of decreasing the neurotransmitter when there is an excess. Yick! Now, some of the older medications are much more straightforward. They are either agonists or antagonists. But the newer meds that we'll be looking at, such as Vibrid and Trintellix, are much more complex. They can be antagonistic at one receptor and partial agonists at another. So it does get quite complex. This stall slide puts it into a pretty picture of a rainbow that is a spectrum, and I like using this image of spectrum to talk about many things, both the action of our medications, but I also like to talk about spectrums in terms of our mood disorders, especially the bipolar disorder and the psychotic disorders. But anyway, let's get back to medications. So the agonist spectrum, we can go from one end, which is an agonist, a full agonist, and then into a partial agonist. I think Stahl's slide here is not complete because he only has one picture for the antagonist. However, there are partial antagonists. And then if you go over to the far right, there is an inverse agonist. He puts that there, but I have not found any medication that is listed in his book as an inverse agonist. We'll explain that a little bit more as we look in the next slide. In this slide, what we see is up at the top, passing through that line is that blue T-shaped, like a golf tee type of form, and then underneath that is the G, which is a G-coupled protein that is bound to an enzyme. And then that enzyme and G-coupled protein has started a transduction cascade signal going into another enzyme that then has third, fourth, fifth, sixth messenger activities. What we need to understand is that a receptor does have a basic level activity that is going on no matter what is happening. And an agonist is going to bind to that T-shaped receptor and enhance its activity. But when there is no agonist, there still is activity. I would compare it to like when I'm sleeping at night, my body is still very active, but when I wake up during the day, it is much more active, much more visible. So no agonist would be like my body sleeping at night. Agonist action would be like my body during the day. Hope that helps. This makes it even clearer that once an agonist binds to that T-shaped receptor up there, it really lights up. It turns orange, and the G protein has changed its shape and conformed, and the enzyme has changed its shape and conformed because an agonist has bound there. And now, downstream, not just one, but 2, 3, 4 more activities are taking place with different enzymes becoming involved. And when those enzymes become involved, they're acting on ligand-gated channels, they're acting on enzymes, they're acting on ions, and all sorts of activity is beginning to take place. When we have an antagonist, we don't completely stop the activity of the receptor. We just return it to baseline, to its constitutive activity. Maybe another image that would help would be that of a stoplight that has red, yellow, and green. Green would be an agonist, which is enhancing the activity. Go, boys, go. Yellow would be an antagonist saying, whoa, gals, slow it down, ladies. And red would be, stop, gang, don't go at all. Another image, metaphor, simile that might be helpful is that of a rheostat that we have on our light fixtures in some of us in our houses, where you can turn the light up to full brightness and really illuminate the room, or depending upon the mood you want to set, you turn it down a little bit or you can turn it down even more, or you can push it and turn it off completely. So a full agonist is the light is at its brightest, the receptor activity is at its maximum. A partial agonist, it is slightly dimmed, but it is still shining, and so there is increased receptor activity, but not to the extent that a full agonist would be. And no agonist, the light is off. That would be, no agonist would be also like an antagonist. There's a constitutive activity taking place that you could possibly, in a darkened room, still be able to see your way around. So it's not that things have completely stopped, but that activity is greatly reduced and only to a constitutive or basic baseline functioning level. The concept of an inverse agonist, I think, is a pharmacological distinction that may be a very fine hair distinction, and we are not going to actually know it in our clinical work, because an inverse agonist in reality is doing what we commonly think an antagonist does. It stops activity at the receptor site. The big difference is it completely stops the activity at the receptor site, whereas an antagonist brings the activity back to the baseline level. So an inverse agonist completely stops. We talk about antihistamines. Some of those are inverse agonists, completely stopping the activity. Some of the beta blockers, such as carvedilol, are also, we call them blockers, but they are in reality, according to fine distinctions, inverse agonists. And then even some of our antipsychotic medications that block dopamine, some of them are antagonists and some may be inverse agonists. This is going to go into the concept also of binding power, how strongly a chemical binds to the receptor site. So inverse agonist, antagonist, partial agonist, full agonist, going from right to left on the rainbow spectrum. This puts it all together for us in one pretty picture, but it just blew away my stoplight image of red, yellow, and green, because they have put the agonist and partial agonist in a red color instead of a bright, brilliant green color. So sorry to be mixing metaphors in your heads, but you'll see on the far left, the agonist action is the full agonist. Has a lot of activity that is then enhanced at the receptor site and down into the multi-signal transduction cascade, and then it keeps going over to the far right, where the inverse agonist has completely stopped all activity at the receptor site.